చెక్ వన్. అది రీప్లేస్ చేయండి మేడం. ఇప్పుడు వెళ్ళిపోతుంది మేడం. వెళ్తుంది ఆడియో. రిపీట్ చేయండి. వస్తుంది. చెక్ ఆడియో 1 2 3 మేడం.
బట్ వేరే ఓటీ లేదా ఆ ఓటీ ఇస్తే ఈ కేసు సార్ ఆ సైడ్కి వస్తే ఈజీ అవుతుంది మీకు. చార్జర్ దాట్ ఆ సైడ్లో కొంచెం ఈజీ అవుతుంది. ఇక్కడ కొంచెం ఇంకా ఇన్స్ట్రుమెంట్ కూడా కొంచెం దగ్గరికి వస్తుంది.
అయితే ఫస్ట్ ఇక్కడ మన దగ్గర దొరికేసి మళ్ళీ ఇక్కడ
स्क्रीन का भी आपने दे रखा है ना?
हाँ देखा
उधर लाइव रिले ऊपर
సెట్ కర్.
కెమెరా ఆ సైడ్ తీసుకోండి.
కెమెరా
ఇదే ఒక్కటే ఆ సైడ్ తీసుకోండి.
सर केबल नियर है सर.
दो मिनट. क्या कुछ वायर अटक रहा है क्या? 2 मिनट. हाँ वी आर वेटिंग.
కేబుల్ ముందు నుంచి పెట్టానా రావాలా? ముందు నుంచి పెట్టా.
हाँ मैडम बोलो.
सर इधर आओ.
ओके स्टार्ट.
ठीक है 1 मिनट ठहरो.
ए रवि स्टीरअप చూడండి.
ఓటీలో స్టార్ట్ చేస్తామన్నారు కదా. ఇన్స్ట్రుమెంట్ ఇవన్నీ ఇప్పుడే తీసేస్తుంటాయి. కేసు మధ్యలో ప్రాబ్లం అవుతుంది. ఇప్పుడే తీపించేసాం. మళ్ళీ ఏంటంటే అక్కడ పెట్టుకోవడానికి కూడా ఇలాంటి ట్రాలీ లేదు. మామూలు అట్లాంటి వాటి మీద సెట్ చేయొచ్చు, పర్వాలేదు. కాకపోతే ఇవన్నీ ఇప్పుడే తీపియండి.
మన సెట్ అంతా తీపిస్తారా?
स्क्रीन्स 55 इंच
దీని మీద పాత సెట్ తీసేస్తాం. తెలుగు అందులో
ये मेरे को कौन सा दिया? ये वाला ना. ठीक है. కొంచెం దగ్గరికి తీసుకో. ఓకే స్టార్ట్. కొంచెం మీరు ఎలా ఆ సైడ్కి వెళ్తా. స్టార్ట్ చేయాలా? లైట్స్ ఇప్పుడు కాదు. ఓకే మీరు కెమెరా ఇక్కడ తీసుకోండి బ్రదర్, డైరెక్ట్ ఇక్కడ 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 పెట్టండి. We'll start with this introduction. ఇదే చూపించాలి. ఇది రొటేట్ చేయి అంతే. అంతే ఇక్కడేనే ఇదే కనిపించాలి. ఏదో చూపించాలి.
కనిపిస్తుంది సార్ ఇది.
ఓకే హలో 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 ఓకే ఓకే. The people here don't talk. Okay. డోర్ క్లోజ్ చేసేసాయి మరి. డోర్ క్లోజ్ చేసేది. ఓకే హలో. So hi, good morning everyone. Welcoming you for this surgical feast. Now rather than wasting more time on theory, directly we'll jump onto the machines. Now remember, laparoscopy is all about machines. Okay, because it is a machine, there sir nahi maatadandi.
Place of one case can be shipped to general order. Fine. That will go to general order. That's better.
ओके अरे यार तुम लोग क्या कर रहे हैं यार, पहले कर रहे हैं वो कॉटरी है ना ఏంది రాజే తీసేసేయి ఓకేలే వెయిట్ ఎందుకు చేయాలి okay so hi good morning everyone now people here please don't talk sister మాట్లాడకండి okay now coming to laparoscopy remember laparoscopy is all about machines because it is a machine there will be so many settings but when I tell you this setting is medically important setting what I mean by that is that setting you need to perform before performing any laparoscopic surgery now when I say laparoscopic surgery what I mean is gynec surgery general surgery all heading of laparoscopic surgery now remember in laparoscopy three machines always goes together okay first is camera so this is camera okay second inside the abdomen there is no light Okay, so we have to put a light. The machine which gives us constant light, we call it as light source. Okay, so that is our second machine, that is light source. Third, inside the abdomen, there is no space. So we have to create a space by insufflating pneumo. I think this much theory everyone know. The machine which gives us constant pneumo, we call it as insufflator. That is our third machine. Okay, so this is our third machine, that is insufflator. Now coming to the first machine, that is our camera. Now don't think laparoscopy camera is like some big high-fundu camera from out of the planet. Okay, it is same like any other mobile camera. Okay, how Samsung mobile camera, Apple mobile camera, different companies mobile camera will give you different photo clarity. Same applies to this cameras also. Okay, grossly speaking, cameras can be divided into three categories depending on the resolution, how much it gives. Same how we watch our YouTube videos, Hotstar videos. Okay, same how we watch our YouTube videos, Hotstar videos. So grossly speaking, three categories. The cameras which gives us resolution of 720 pixel. Okay, we call it as HD cameras or high definition cameras. Another variety is 1080 pixel. Okay, what we call it as FHD cameras or full HD cameras. Another latest addition into this camera category is nothing but 4K. So we have brought 4K for you. This is the latest. Okay, 720, 1080 pixel, 4K is nothing but 4000 pixel. Okay, now what is pixel? Let's say this is screen. If you divide screen into small 4000 cubicles, then one cubicle can be called as 1 pixel. Simple language. Now out of all these three, 720 pixel, 1080 pixel, 4K. If you ask me personally, how much it is needed to perform lap surgeries without facing any difficulty. Okay, I would say 1080 pixel is more than enough. Okay, full HD is more than enough to do all your lap cases without facing any difficulty. But at the same time, let's say you are too much into technology. You like wider screens, big pictures. Okay, and definitely at the end, if your father or you are rich to afford for 4K. Okay, because this camera alone, Ravi Anta, camera alone is around. So that much amount of money patient also doesn't pay. Okay, so because of that thing. Now, as I told you, 1080 pixel is more than enough. Now, apart from this, there is nothing inside this machine. Okay, I will give you an example like when you purchase a new TV, let's say, new TV. Every time you want to watch a TV, you don't change the settings, color, contrast, brightness, this, saturation, all these things, you keep it like that only. So when you purchase a new TV or new camera, there will be default setting. Okay, so keep the default setting, just switch it on, start watching. The same you do it with TV, the same here. Okay, just switch it on, start performing. Okay, I'll come back to this machine again after explaining you the second machine. See, some cameras will give you video recording, some cameras will give you photo snapshotting. These features are additive features. Okay, this is not important to perform surgery. Okay, so again I'll come back to this machine after explaining you the second machine. Coming to the second machine, that is light source. That is light source. Okay, now remember, in entire world, okay, there are only two bulbs. In this machine there is nothing but only one bulb is there inside, which is emitting perfectly white light. Now in entire world there are only two bulbs which emit perfectly white light. Okay, one is xenon bulb, another is LED bulb. This two gives you perfectly white light. Okay, now differences between the two. Okay, coming to in terms of quality, xenon will give you more of like a natural light or like a room light like this. This is also white. Okay, but it is slightly yellow, tingy yellow. Okay, whereas LED will be like that. That is LED tube light. That is LED tube light. Okay, LED will be perfectly white. Another difference between the two is the cost. Xenon is 3 times costlier than LED. Okay, so in simple language, all the German manufacturers or all the developed countries manufacturers, they make the machine with xenon. All the Indian manufacturers, they make the machine with LED. Okay, now this is in terms of quality I told. Okay, this is emitting at 20 watts. Okay, so another question is, how much quantity of light do we require to perform lap surgeries without facing any difficulty? Remember, we are gynec surgeons, we are pelvic surgeons. We operate in a closed space of pelvis. For us, our operating space is like a hall. Okay, so for us, 80 watt is more than enough. 80 watt is more than enough. But let's say in your center, you are operating in multi-specialty or like this. Okay. So in your setup, if some general surgeons are coming, and let's say when they are operating in the flexure areas, hepatic flexure, splenic flexure, okay, those areas are relatively darker areas in contrast to our pelvis, which is like a hall. Okay. At the same time, it contains angulations. Okay. But for those cases also, 120 watt is more than enough. For us 80 watt, for those cases 120. So can I make a statement that 120 watt light source is more than enough to do all your cases without facing any difficulty? Right? Now, what is the use of this knowledge? Because when you go for purchasing, they will tell you, okay, you will see that manufacturers are making the machine with 200 watt, 250 watt, 300 watt. Okay, let's say you have purchased 200 watt machine. Now, my very good friend Alan, they have made it 200 watt. Okay, so 200 watt machine. Once you purchase the 200 watt machine, once you go inside, you will see picture is too bright. Then you will have to reduce the intensity. Okay, let's say you are reducing the intensity by 30-40%. That means indirectly you are bringing the machine from 200 watt to 120 watt. Rather, you can purchase 120 watt machine and operate at 100% intensity. Cost cutting. See what they put. Why? For that. Okay, so rather you can purchase 120 and directly this thing. This is just marketing gimmick. Okay, so you create so many products so that consumers get confused what to purchase. Invariably, they'll end up purchasing the highest one, thinking I'll get the more light there, but not true. Okay, so xenon LED, depending on your financial budget, okay, you can go ahead. Xenon light source will cost you more than 2 lakhs, LED 50,000. Okay, so if you ask me personally what to go ahead, I would say 120 watt. Okay, at the same time, I like more bright, and at the same time, it doesn't create a big hole in the pocket. Okay, 120 watt LED more than enough. Okay, this is 200 watt LED, but at the same time, we are operating on 4K, so we require more light. Two machines clear, camera, light source. Now, camera, light source combining together when it is attached to a telescope. Okay, there is one medically important setting, what we call it as white balance. Okay, now understand what is white balance. White balance in simple language, white balance is nothing but you are telling the camera that this is white. That is white balance. Okay, why white? White, presence of 3 primary colors, red, green, blue. Okay, in equal proportions. So can I make a statement that when I am doing the white balance, I am doing nothing but I am setting up the color perception of the camera. White is color. Okay. So remember, white balance has only thing to do with the color perception of the camera. It has nothing to do with the quality of the image. Okay. So to do the white balance, 2 prerequisites. Okay. First, hold perfectly white object in front of camera. Okay. Second, that object should not be transparent. It should be opaque or else light will penetrate. Okay. So the best object on a trolley, it's not a gauze piece. Gauze piece is transparent. Best object would be mop. Mop which is not reused. Mop which is not turned yellow. Mop which is perfectly white. Okay, now hold the object. Whatever system you purchase, German, Indian, mine, whatever system you purchase, there will be one dedicated button to do the white balance. One dedicated button will be there. Hold the object, press that button. Now when you are pressing the button, camera will consider whatever in front of it as a white and will adjust its setting automatically. Now let's say okay, that object is like yellow or some yellow light is falling on that. Okay, now considering that you have press that button. Now camera will consider yellow as a white. Okay, and will adjust its setting automatically. Now what will happen once you go inside? Once you go inside, you will see that tissue is not looking like how it is supposed to look like. Okay, or there is some greenish, bluish, some hue is there. Okay, that means white balance, you have not done it correctly. So come out, do the white balance again. Now go inside. Now tissue is looking like how it is supposed to look like. But image quality is not good. That means camera is not good. It has nothing to do with the white balance. Why I am telling you this is I have seen so many surgeons, anything wrong with the image, any problem with the image, they will tell only one thing, come out, do the white balance. No. Understand the funda of white balance. Okay, so white balance has only thing to do with the color perception of the camera. It has nothing to do with the image quality. Funda of white balance clear. Two machines clear. Light source, camera. Now coming to the third machine, that is Insufflator. Now in this machine, remember there is whatever company Insufflator you purchase. Okay, there will be 3 columns. First is pressure, whichever company, Indian, German, whatever you purchase, there will be 3 columns. Pressure, flow, and here it is evac, but there is another column, that is volume. In this machine, remember there is only one medically important setting, and I feel like all the settings of the machine you only should know. You should not rely on the OT technicians for the settings of the machine. Okay, if they also don't know, they'll take you for a ride. Madam, alage untundi. It will be like this only. Before you, so many surgeons, so senior surgeons came and they operate on the same thing. Okay, so that's why don't rely on them. All the settings you only should know. Now coming to the insufflator, as I told, 3 columns. One medically important setting in insufflator is set pressure. Okay, set pressure. Now remember, to operate any laparoscopic surgery. Okay, again, when I'm saying laparoscopic surgery, gynae lab, general surgery lab. Okay, any laparoscopic surgery, set pressure should be between 14 to 16. Remember. Okay, 14, 15, 16, whatever you like. 14 to 16. They have kept it at 12, so it should be 14 or 16. Okay, we'll change it. Second is flow. Flow is liters per minute. Okay, so in simple language, machine is asking you, you have set the pressure to 14. The machine is asking you how fast you want me to reach there from 0 to 14. That is flow. Understood? Okay, so pressure is set to 14. From 0, how fast you want me to reach there, that is flow, that is liters per minute. If anyone asks you how fast you want to do the surgery, obviously answer would be fastest. Okay, so can I make a statement here? As far as pressure is set to one level, flow doesn't matter. How fast, how slow I want to reach that doesn't matter. Okay, once it reaches to your set pressure, automatically flow is going to go 0. That's the whole purpose of the insufflator. Okay, so as far as pressure is set to one level, so flow doesn't matter. So keep it, madam. Which?
Set flow and flow rate.
No, that's what I'm coming. Okay, once the pressure is set to one level, whatever your machine can deliver maximum, keep that flow rate, because that doesn't matter. Okay, this machine can deliver maximum at 30. They have set it 30. So we will keep it 30. We will change it, we'll keep it 30. Okay. Remember, pressure is more important. Surgical side also, anesthesia side also. Pressure is more important, not the flow. Okay. If, let's say, you are operating, common doubts. If you are operating small abdomen, pediatric case, pressure will be 14 only. Okay. Pressure will be 14 only. Maybe to reach to that pressure of 14, you will require less volume of gas. Okay, whereas operating obese woman, bariatric case, large patient, pressure will be 14 only. Okay, but to reach to that pressure of 14, you will require large volume of gas. Pressure is different, flow is different. Okay, so once you go from here or once I go from here, okay, there will be so many brains inside OT. They'll be telling you continuously, "Arey, flow itna kar diya, pressure itna bada." The same statement you should tell. As far as pressure is set to one level, flow doesn't matter. Okay. So, understood the insufflator? 3 machines, camera, light source, insufflator. Now coming to the 4th machine, that is monitor. Now remember, we can operate on TVs. You can operate on computer monitors. You can operate on that big cathode ray tube. You can operate on laptops. If your camera can get connected there, you can operate on that. Okay. But when you go for purchasing, you will hear there is something called as medical grade. Okay, madam, this is medical grade monitor. Chala bound. Okay, so what is the difference between all this and when they say that this is medical grade monitor? 2 technologies, any monitor or any TV per se, which supports HDR10 and 1 billion color. If you watch Hotstar, the Amazon Prime videos, sometime it will come. It supports Dolby Digital. It supports HDR10. Now you look, you will understand now. So any monitor or any TV which supports HDR10 and 1 billion color can be sold like a medical grade monitor. But to be sold under the heading of medical grade monitor, they have to purchase licenses from the government. So let's say cost of any monitor is around 20 to 25,000, which supports both these things. But after purchasing licenses, cost goes till 2 lakhs. Okay. So knowing this funda, we have produced something like unique, that is in another OT. Okay. But this is like top of the art. So this will go till 42 lakhs as he said. Okay, so for budget we have created something else that we'll be seeing in the next case. Okay, so monitor, okay, camera, light source, insufflator, monitor. Okay, now quick, fast, because they are waiting. Now coming to the last and most important machine, that is the cautery machine. Okay, I feel like whenever you start operating, all the settings of the machine, as I told you, only should know. Okay, because when we were learning open surgery, remember, okay, at that time in medical colleges, you will be telling your residents, okay, to practice knots. Why? Because that is most important. Okay, when it comes to laparoscopy, it is everything about the cautery machine. So you only should know in and out. Pen, paper. Two minutes. That's pen, paper. Paper. Okay. So coming to, there are two forms of energy. There are two forms of energy which we use worldwide to do lap surgeries. Okay, one form of energy is called as electrical energy. Electrical energy, you all like able to see. Electrical energy getting converted into heat energy. Okay, the machine which does that, we call it as ESU or electrosurgical unit. Okay, your normal unipolar, bipolar. Okay, another form of energy what we use worldwide is ultrasonic energy. Okay, ultrasonic energy, again end result is same, that is heat energy. Okay, the machine which does that, we call it as ultrasonics or harmonics. Okay, now coming to this thing first. Okay, this thing first. Now ultrasonics and harmonics, remember these were the pioneers. Pioneer means like when lap was new in India. Okay, back in 2003, 2004, when we were learning in India. Okay, so these were the people who started giving instrument. Okay, so these were the people who started giving machines and instruments. Okay, for the doing lap surgery. The people who started back in 2003, 2004, they started on this. Okay, the people whom they taught, they are still using this. But the problem with this is the cost. Okay, the cost of the generator is around 13 to 14 lakhs, depending on the state where you're from. Here, Telangana, around 13.5. Okay, cost of the probe, harmonic probe, is around 45 to 50,000. Again, depending on the state, here also 45 to 50. Let's say you purchase the probe for 50,000. Okay, now in the best of the best hands, who knows the machine, who knows the instrument, in those hands also, this probe will come for maximum 5 to 7 uses. Maximum, I'm telling. Okay, the people who are totally new, okay, for them it is 3 to 5. 3 cases also sometimes it goes. Now let's say you purchase for 50,000. It came for maximum 5 cases. That means to do the case, your investment is around 10,000. Okay, because of this, you remember lap was never possible outside tier 1 cities. Okay, so you remember only Mumbai, Delhi, Hyderabad, where patient paying capacity is good. Okay, where like 1.2 lakhs, 1.3 lakhs, where they are paying. Whereas in periphery, where entire surgery is over in 30 to 35,000, it is not even feasible. Okay, because of this thing, there was always a need to replace this machine. Okay, because of this thing, there was always a need to replace this and find something more economical. Okay, now we have completely replaced this. As I told, I am gynae onco. We do lymph node dissection also with this. Okay, now there is myth going on in the market. Okay, if you use harmonic, there is less lateral spread. If you use harmonic, it is like less harmful for the patient. Okay, if it is like that, just hold bowel with harmonic and fire. Okay, so it is not like that. It is knowing the machine and knowing the instrument which makes surgery more safer, and not about the instrument. The instrument doesn't have brain, right? So we don't use this thing at all. Now coming to the ESUs. ESUs can be broadly classified into 2 categories. One, what we can call it as a normal cautery. Another, what we can call it as a sealing cautery. Okay, in normal cautery, you will be getting bipolar and unipolar. In sealing cautery also, you will get bipolar and unipolar. Okay, in normal cautery, for bipolar, you will be getting one single pedal by default. Okay, that is by default bipolar coag. Okay, in unipolar you will be getting two pedals, that is cut and coag. In sealing cautery, for bipolar also you will be getting two pedals, that is cut and coag. And unipolar also you will be getting two pedals, that is cut and coag. Understood the gross difference? So just by looking at the cautery, how can you tell whether it is a normal cautery or sealing cautery? Ask for the foot pedal. Okay, if that machine has given you two pedals for bipolar, in unipolar you will be getting two pedals for everything, all the machines. Okay, but bipolar, if they have given you two pedals, then it is a sealing cautery. Okay, see, we Indians have a habit of judging things by the cost of it. Okay, so if you enter the OT and if you ask what cautery you have, so people will tell you that this cautery is of around 10 lakhs. We think like, no, it has to be good. 10 lakhs ka machine. Okay, but not true. If it is given you single pedal for bipolar, okay, then still it is a normal cautery. It is not a sealing cautery. Okay. Now coming to cut and coag. Remember, just for a time being, because patient has been induced, cut is not for cutting. Coag, it is not for coagulation. It is a misnomer created long back. Okay, and we are still following it because we doctors are idiots. I'm telling you on national platform. Okay, because we doctors are idiots. We don't give feedbacks to the machine manufacturers. Okay, we don't tell them like, array, this is not working. Array, this is not giving good effect. So they also don't know. Whatever they learned 20 years back, they've still continued. Okay, but I'm not a brand ambassador of Allen, but we are a fan of Allen. Okay, so they launched this machine. They launched this machine back in 2016. Okay, and we started using since 1 month later. They understood all these things, that cut is not for cutting, coag is not for coagulation, and they understood and they have changed everything backside. And as far as my knowledge goes, they have a patent for this. Okay, so what modifications they have done, we'll discuss it like theoretically later. Okay, after the case. By using this machine is very simple. Okay, so this is sealing machine. Now when you want to use bipolar, array, Ravi, lock lo unda, unlock say. Okay, so when you want to use bipolar, okay, they have written whatever here they have written, it is same. If you are using Allen cautery or one another player is there in the market by Shalia, okay, if you are using these two machines, whatever they have written, it is same. If you have any other machines than Allen and Shalia, remember it is opposite. Okay, so using this machine, when you want to use bipolar seal. Okay, I want to use cut with bipolar cut. Okay, let's say I want to use unipolar in between. Okay, you can see this orange button. This is nothing, this is just for show. Okay, so press this orange button. You got the sound. Function by. See, now it has gone to this side. Okay, that means machine has got converted into unipolar. Okay, so now unipolar will work. So unipolar cut, unipolar coag. Okay, coming back again, converting the machine. Okay, this is Bluetooth. Okay, so converting the machine to bipolar. This is bipolar. Okay, so pedals have gone there. See, this is pedals. Okay, the pedals have gone there. So bipolar will work. So bipolar seal, bipolar cut. I want to use unipolar in between. Press this orange button. Okay, unipolar cut, unipolar coag. Simple. Chalo, we'll start now. Bipolar seal, bipolar cut. Okay, I want to use unipolar, convert the machine. So cut is same for both of them, provided machine is in that mode. Yeah, this is for bipolar. Okay, chalo. The person who is operating, stay here, rest come this side now. From there also it will be visible, same position. No.
Yes, here is.
Yeah.
There is only one place. అది కూడా ఇచ్చేసేరా ఫాస్ట్ ఫాస్ట్. ఆ స్మోక్ ఎవాక్యుయేటర్ వద్దు, స్మోక్ ఎవాక్యుయేటర్ వద్దు, ఓన్లీ ఇన్సఫ్లేషన్. ఇక్కడ స్మోక్ ఎవాక్యుయేటర్ పోర్ట్ ఉండాలి. చూద్దాం. అది వేరే పోర్ట్ లో పెట్టాలి. టవల్ క్లిప్ తీసుకో. ले लो किसको बड़ा भर भर के पूरा है
Okay. So now coming to the next step. Next step is to create a insufflation. మాట్లాడకండి ఇక్కడ सर हाँ ले लो सर ले लो पूरा 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 साइड खाली आप ध्यान रखना इधर उधर रखे नहीं नहीं आप पूरा ले लो वहां पे पूरा का पूरा ले लो साइड एक्सटे you come this side ma'am anyway the visibility will be there only okay so you come that side so that when I'm explaining it will be okay table మొత్తం డౌన్ ఉందా సార్ ఫుల్ డౌన్ చేయండి సార్ maximum అనుకుంటా the maximum maximum తీటా ఉందా మీ దగ్గర ఇక్కడ మీకు కొంచెం ఓకే తర్వాత మళ్ళీ డిస్టర్బ్ చేస్తాను anyone who wants to come let them come or else just close it okay now coming to the next step is to create a pneumoperitoneum Ravi okay so next step is to create a pneumoperitoneum to create a pneumoperitoneum remember there are 3 techniques okay first technique is go through varies put varies create insufflation then put a port okay this is first technique second technique is direct entry okay just hold put a trocar directly inside okay third technique is open technique also called as Hassan's method where you cut okay reach to the peritoneum cut now coming to this third technique is obsolete now no one does okay because see the diameter of this thing is 1 centimeter 10 millimeter you cannot operate in 1 centimeter incision okay you will tend to have at least 1.5 to 2 centimeter incision okay with this much amount of cut gas will leak okay with the movement of telescope port might come out adding to all these things it is time consuming now sir because of all these reasons that third technique no one does now comparing first and second technique that is creating insufflation with varies then put a port or go direct now comparing both this now let's say you are going here okay what are the structures you are worried of first structure running will be transverse colon okay more careless some bowel loops more careless direct aorta okay if you puncture all these things let's say bowel loops with this okay it is going to be a pinpoint puncture right so nothing you just leave patient NBM for 48 hours automatically that pinpoint puncture is going to get sealed even if you puncture aorta with this obviously it is going to ooze torrentially at start but it will form hematoma and because of the peritoneum overlying it will act like a tamponade okay that also stops that also we have seen but let's say you are going direct and you puncture all these things with this okay there is less time to save patient and yourself both okay so always safety first so varies first right now coming to varies remember varies works on the principle of spring action this is blunt okay when you push blunt end will go inside and sharp end will come out okay when there is no obstruction to the tip automatically blunt end will come out this coming of this blunt end creates a sound okay this is called as click remember click okay so like this sound is called as click now where to put the varies okay there are 2 points which is recognized worldwide one point is called as Palmer's point which is mid clavicular line subcostal margin 3 centimeter below this is Palmer's point another point parallel to the palmar point, somewhere in between umbilicus and xiphisternum. This is called as Lee-Yuan point, L-E-H-U-A-N, Lee-Yuan point. Okay, why these 2 points? Because these 2 points are adhesion free in your 99% of the cases. Okay, because of 2 reasons. First reason, most of the surgeries happen here, no adhesions. Okay, second reason, let's say even if adhesions have started forming from POD1 in patient, okay, but all of us eat, patient also eats from POD1, okay, because of the eating, stomach expands. Stomach doesn't expand caudally, it expands this way. Because of the expansion of the stomach, okay, even if adhesions have started forming from POD1, it will push the adhesions, making these 2 points adhesion free in your 99% of the cases. Okay, still not able to enter these 2 points, go anywhere. Okay, now differences between the two. To enter peritoneal cavity at palmar's point, okay, you need to listen to 3 clicks, first, second, third, 3 clicks. Okay, first click will come when you pierce anterior rectus sheath. Second click will come when you pierce posterior rectus sheath. Third click will come when you pierce peritoneum and you are in. Okay, whereas at Lee-Yuan, 2 clicks, rectus sheath is fused. 1 click for the rectus sheath, 1 click for the peritoneum, you are in. Another difference between the two is this become extra incision to the patient or extra nick to the patient because none of your port is going to come here. Whereas this, the same incision you can enlarge, make it 10 mm, you use it like a camera port. Right? Where to put the camera port? Remember, as high as possible. Your camera has a triangular vision like this. If you put a camera, let's say at umbilicus, vision will be this much. Okay, higher you go, better will be the vision. Okay, remember this port is developed by general surgeons. Okay, for their ease. Okay, to operate most of this thing, they started with lap Coley. Okay, so they invented this port that put this here and it will be cosmetically good. Okay, but our primary interest is in pelvis. Okay, let's say uterus has grown more, or let's say with the traction and pushing from below. Okay, uterus will come till here. If you put a camera port here, you will be continuously kissing the uterus. Okay, so simple language, higher you are, better will be the vision. So in 99% of the cases, we use Lee-Yuan as a incision site for the varies and incision site for the camera. Okay, go ahead. Okay, stab incision at Lee-Yuan point for only varies to enter. Technician, కొంచెం right tilt ఇవ్వబ్బా. Right
side.
Stab ma'am. Madam ki pita ఇవ్వండి ma. Okay, now you are only your own assistant, you are not going to use any assistant and no sisters for lifting and all. Okay, you only have to lift. Okay, now all the instrument, all the trocar entry always perpendicular. No tangential, not going here and there, always perpendicular. Remember, all the varies, all the trocar should travel minimum distance in the abdominal wall. Okay, so skin here, rectus sheath here, peritoneum here, all 3 in the same line. Okay, if you put skin incision here, rectus sheath incision here, peritoneum here, okay, the trocar gets fixed in that direction. You won't have a 360-degree movement. All the entry perpendicular. Okay, now putting varies, ulta. Our side ki pura. Right up cheyali. Chay. Chal. Okay. Now you are only your own assistant, as I told. You are right-handed. Yeah. No. So coming to holding thumb, rest of the fingers, put it in umbilicus, opposite side, not in the center, not towards you, and definitely not like this. Okay. Always opposite side. See, remember, we have to create a tenting effect inside. Tenting effect will be created if you hold opposite side nicely. This, like this, will be just lifting the fat and not the rectus sheath. Okay, go ahead. Feel the 2 clicks. Push. Be confident. Push. Every time you are out. Okay, just leave it. Now leave the varies, leave that thing. Now, next step is to check the varies whether she is in or not. Okay, to check the varies, 3 methods. Okay, first is called as hanging drop method. Hanging drop method, you put a drop of saline over this because of the negative intra-abdominal pressure. If it will get sucked in, that means you are in. First method. Second method, take a 2cc saline syringe. Okay, pull, bubbles are coming, push, freely going, that means you are inside. Fastest way, what I prefer is you have a machine here. There. Okay, so you have a machine here. Just connect the machine. On pressure, flow, aim, march. Pressure 14.2, flow 13, 30. 14, 30, flow 30. Flow రా మధ్యలో maximum ఎంత 40 పెట్టేసి. Okay, so we have a machine, so we just connect the machine and see that pressure, actual pressure. See, first is 14, second is 6. అక్కడ చూపించు. Okay, so you have fixed it at 14. So slowly that is going to rise. See, it is showing 4. That means that there is no obstruction to the tip of the varis and gas is freely flowing inside. Okay, so now you have set the pressure to 14. Slowly it will rise from 4 to 14, 4, 5, 6, 8, 9. Now it has become 9. Okay. Good question. Suppose if it is in the pre-peritoneal space, suppose you are above rectus sheath, okay, because then gas won't be able to go freely, right? So it will give you higher pressures. It will show you some 20, 25. If it shows you single digit, it started with 4. So anything 4, 5, 6. That means the tip of the varis is free and gas is freely flowing inside. Okay, let it get rise. Okay, now let the gas fill. Okay, now let the gas fill. Till that time, remember the people who are new, the people who are already putting the ports, for them it is okay, or who are not putting ports at all, remember your thenar eminence. Thenar eminence is the pressing point. Thenar, hypothenar. Thenar eminence, pressing point. Put your index finger here, grab it firmly. Okay, while going inside, you should be screwing more. This is screwing. Screwing more and pushing constantly. Mark my words. Screwing more and pushing constantly, and not the vice versa. That is pushing like hell. Okay, but screwing like this only. Remember, this tocar has triangular blades. See, 1, 2, 3 triangular blades. Okay, this will cut only if you screw. Okay, there is no role of pushing. Okay, and last the incision one. కొంచెం ఇక్కడ చాలా పైకి అయ్యింది. 1 centimeter only skin. Ravi, కొంచెం ఆ సైడ్ ల్యాప్టాప్ ఉంది అక్కడ ఆ సైడ్ కొంచెం. Go ahead. Okay, again you will be holding the same. Hold it here. Now this is not for lifting. Okay, this is just to support your left hand. When your left hand is supported, you will get pressure in your right hand. Always perpendicular. Okay, go ahead. Screw. Skin incision adequate. Skin incision. Hold. Now go start screwing. Go ahead. Screw. Constant push inside. Screw. Push it. Screw faster. Don't push. You felt it? So this is piercing of rectus sheath. Here in this you won't get 2 clicks. This is larger diameter. Okay. Light source. ఆ లైట్ ఆఫ్ చేప. Okay. Now coming to entry, remember you have come here. Your varies, your 10 mm, everything has come here. So even if you have punctured anything, any structure, అక్కడ కూడా చూపించాలి ఆ టైంకి. మీకు ఇంగ్లీష్ అర్థం అవుతుందా? వెరీ గుడ్, ఫోకస్ చేయండి అక్కడ. సో రిమెంబర్ your varies, your this thing has come here. So even if you have punctured anything, this will appear here. After checking only, ask for the head lobe and not before. If you ask for head lobe before, even if you have punctured something, that is going to go up. Never you will be able to see. Okay, sir, head lobe. मेरा नहीं. पिकअप कौन है? बात कर. सर्जरी में फोन करता. पीछे से हेड लो चाहिए फास्ट. Go continuous. Do history. What is the history? Previous 3 LSEs. You took direct previous 3 LSEs. Can explain you. Okay. Now coming to putting the secondary ports or operating ports. Okay, remember hysterectomy is simplest of all gynec procedure. It is destruction. Any ectomy per se. Okay, it is destruction. So it is simplest. It is level 1. Okay, whereas cystectomy, myomectomy, these are level 2. Okay, so for hysterectomy, ideally in normal case, this is previous 3 LSEs. Okay, in normal case for hysterectomy, only 2 ports are enough. Only 2 ports. Okay, at the level of umbilicus, making an obtuse angle with your camera port. Okay, so this is your this thing, obtuse angle. Don't go by centimeter, 4-5 centimeter from umbilicus. This, see, remember centimeter wise, if you go in cases of smaller abdomen, that 5 centimeter might be very much lateral. In cases of large abdomen, this will be very clear. Okay, so never go by centimeters, always by angle. So obtuse angle. So one port of yours will come here, one here. Go ahead. 5 millimeter. Ravi, pani. Madam, I'm okay. Screwing more, pushing constantly. झाला का सर? घ्या ना. हे का? तिथे screw fast. Okay, and when you are putting operating ports, okay, try holding the port. It will give you confidence, so that when it pierces, your left hand will prevent the overshooting. Okay, man. Screw. Go ahead. Screw faster. Push secondly. Screw. Okay. Take out the trocar. Brother, right up. Go ahead. One here. Not this. Go ahead with port.
old world.
Chai? Chai continuous? Go ahead. Perpendicular, don't travel in the abdominal wall. I'll free the adhesions. Okay, so this is the case with umbilical hernia also. So I'll just free the adhesions and give it back to ma'am. Ravi, foot pedal. Come this side, ma'am, 1 second. Pull. Obviously, there is large hernia with irreducible content. So that is the rectus sheath. You can see this one. She already underwent this thing also, I think. They put some stitch or something there. Okay, so simply I can see now it is only omentum. So simply I'm going and simply chopping it off. Hold. Focus here. Touch it. Come back. Sir, क्या हुआ? Okay, so this क्या हुआ सर? इधर आओ। లోపలికి వెళ్ళరా? Okay, so this case is of previous 3 LSES. You can see some bladder adhesions are there. The rest of the adnexa is okay. Okay, so we are okay. Now remember, coming to the next step. Sigmoid okay, baba. Now remember, okay, okay. So, అక్కడ ప్రొజెక్ట్ అవుతుంది కదా, మరి అదే ఎందుకు ఇక్కడ మరి okay. So now you are right-handed person. Now remember, like she is right-handed, so you are dominated on your right hand side. Now remember, you should always operate your dominating side first. Okay, so you should operate right side of the uterus first. Now remember, whichever side you are operating, your sealing device, whatever you are using, ligature, harmonic, shearer, sealer cutter, whatever you are using, you are మాట్లాడకండి మా నేను కూడా ఇక్కడ మాట్లాడితే ఎలా? Okay, so as I told, like, remember, you should always operate your dominating side first. So you are going to operate the right side of the uterus first. So remember, whichever side you are going to operate, your sealing device will come from the same side. Okay, ligature, harmonic, whatever will come from the right side. Okay, for traction in hysterectomy, we use myoma spiral. Okay, so myoma spiral will come from left. Okay, go ahead. All the sharp instrument, all the electrical instrument. Okay, if camera is showing somewhere here, you won't enter. Okay, you will ask your cameraman to show. Please open now. Okay, now enter. Go ahead. Yeah. Okay. So how to place a myoma? You are going to come and place close to the right cornua. Okay. So this is cornua. Sir, take center rod back. Little bit. Okay. Now how to put a myoma? You will place the myoma in entire surgery. Remember. Okay. There is no pushing, pulling. No force is required anywhere. It is only two fingers. That's all. Okay. So this is right cornua. You will come closer to the right cornua. How to place myoma? I place the myoma. Create a depression. You have created a depression. After that, there is no pushing required. Only screw. Go ahead. Screw, screw, screw. Screw. Start screwing. Yeah. Keep screwing faster. Okay. Make sure in entire process your myoma is perpendicular to your uterine surface. If myoma goes tangential like this, okay, so chances of it coming out again and again will increase. Okay, so always make your uterine surface perpendicular to your myoma and put rest of the myoma spirals. Okay, go ahead. Put entire myoma. Push and okay, come this side. Now you will take that in your left hand. All women here, they drive car?
Yes.
Madam, you are more important. You drive car? So why I'm asking you that is, if you drive car, you don't look for clutch and accelerator down. Okay, you look front only. Okay, so here also same panda. You know that you are going to use, you are using bipolar. Okay, so you know that you are going to use first and second button. Okay, so no need to look it down. Maybe your initial first 2 cases you might have to look down, but don't make it a habit. Okay, so keep your foot rested in between these 2 buttons. Matlad kandi. Okay, so keep your foot rested between these two buttons so that without even looking there, I know my left side is my seal, right side is my cut. Okay, go ahead. Every time. This, so we are using manipulator only, na? Below. సిస్టర్ ఇక్కడ ఫార్మసీలో సావ్లాన్ లేదు, అడగండి 10 రూపీస్ బాటిల్. నెక్స్ట్ కేసులో అడగండి. కోడ్ కోడ్ రా, ఫాస్ట్ ఫాస్ట్. ఎవరికి అక్కడ? వద్దు, తర్వాత స్టార్ట్ చేద్దాం. మీరు టీఎల్హెచ్ స్టార్ట్ చేయండి, హిస్టోస్కోపీ ఇస్తాను. This. Okay, now remember funda. Okay, now you've held the instrument. Okay, I didn't go into theory because the patient was anesthetized at that time. Okay, so theory is, remember, whenever you want to achieve a seal, I think you must be teaching your students, okay, when you are doing hysterectomy, okay, at that time don't fight with the tissue. Everyone must have told. Okay, what do you mean by fighting? Is like creating the traction on the tissue. Okay, so remember, sealing time. Okay, sealing time, tissue should be relaxed. What is your aim? Your aim is to create a good coagulum. Okay, your good coagulum is created. Good coagulum is created when tissue is relaxed. Okay, so sealing time, 2 funda, 2 rules. Okay, hold maximum. Remember, sealing time, hold maximum. Okay, second, tissue should not be under traction. Okay. So now this is hysterectomy. So if all three structures are coming together, we will go and hold it. If it is not coming together, you go separately. Okay, it is coming together, go and hold first. Okay, now it is holding. You are simply holding. What is traction? What is fighting? If she pushes like this is traction. Pulls like this is again traction. Okay, tissue is like this. Keep the tissue like this, relaxed. ఏమైంది సార్? లేలోనా ఎవరా? रवि నువ్వు ముందు అక్కడ మన हिस्टोस्कोप यूज सर, आप यूज करके उसको दे दो. ओके, लो सर, ले लो गो अहेड मैम. फायर बाइपोलर कॉटरी ఎక్కడరా? कॉटरी मशीन ఎక్కడ? Okay, so you will fire continuously at one location till bubbles stop. Bubble stop, you stop. Okay, it looks like a video game, but don't think like it is a video game. Think like a surgery only. Okay, so surgery means only execution you should not learn. Okay, your brain also should learn. Okay, so here tip will be fire continuously at one location till bubble stop. Bubble stop, you stop. Okay, so you have fired there. Now open. One shot medially. Go ahead, fire. Good. Okay, go again. Keep it like this. Okay, so first shot you gave here, one more shot medially. So at least 3 location, one center, medial, lateral. Okay, fire ma'am. Hold, fire, at least like 3 centimeter. Okay, no bubbles, no firing. Okay, recheck medially also whether it is bubble free or not. What we are checking, that is whether it is bubble free or not. Bubble free, it's a sign of completion. I'll walk you through theory. Okay, once this case is over. Okay, for the time being, bubble free is sign of completion. Bubble free means tissue is nicely cooked. Okay, no bubbles means tissue is nicely cooked. Tissue is ready for cut. Okay, now wait. Scissor ekkada? Okay, so this is scissor. Ma'am, Lakshmi. So this is scissor. Okay, this is cold scissor. Okay, how we cut with this instrument? You take little amount of tissue, you completely close the instrument take little amount of tissue, completely close the instrument. That's how tissue gets cut. Okay. That is also scissor, but that is hot scissor. Okay. So same action, keeping the instrument open and close. Okay. Same action you have to do. I call it scissoring action, but with current. Everyone? Okay. So coming to theory over, now practical. Now she wants to cut. Sealing, what I told, 2 rules. Hold maximum. Second, the traction should not be there. Okay, tissue should be relaxed. Cutting, exactly opposite. Okay, cutting, there should be traction. So create traction. Okay, now she is creating the traction. And in sealing, you will hold maximum. In cutting, you will try to do with the tip of the instrument or little amount of tissue, not maximum. Okay, and you will do same scissoring action, like imagine like a scissor. Okay, so we will go, we will keep the instrument open. Okay, we will keep the instrument open like this. Okay, now activate the cut current, center button, and we will close. One more time, open. Don't press, open. Okay, reach there. Same like a scissor. We reach there. Okay, we kept it like a scissor open. Now we will activate and we will simply close. Okay, open one more time. No holding. You want to cut or seal?
Seal.
Seal. Gynec, that's a beauty. You see the RBC, you run behind sealing. Okay, go ahead. Seal. Okay. Okay, nothing is coming. See, your RBCs are not responding. Cut it, ma'am. Cut it. Cut. Scissoring action. No pushing required. Stop, 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 stop.
Yes, sir.
Okay. Now you want to seal. Okay, so hold it maximum. Hold it, hold it, hold it. Now fire seal. First button. Enough. Okay, now stop. Now she has cut the adnexa. Now understand any surgery you want to learn. Okay, you should learn the anatomy first. As I told you there. Okay, you should know the anatomy first. Any surgery, anatomy plays 90% role. Okay, 5% is knowing the instrument with what you are going to do the surgery. And remaining 5% is only surgery. Execution. Okay, so understand the anatomy. Okay, this is adnexa. Once the adnexa is down, okay, what is broad ligament? Broad ligament is nothing but 2 folds of peritoneum which comes like this and gets adhered to the uterus. Okay, what are the contents of broad ligament? Only 2 structures. Okay, that is uterine artery and uterine vein. Your favorite structure, that is ureter. Ureter is not a content of broad ligament. Ureter stays in the lateral pelvic wall. Okay, so ureter is this one. This one. See, you will see the peristalsis. Just focus. See, this one is the ureter. This one. This. Okay, just wait here. You will see the peristalsis. Okay, like, assume that is only ureter. Don't assume that is only ureter. Okay, so this is ureter. Somewhere here, if you see, somewhere here, it is overcrossed by the uterine. Maybe in the next case, I'll go retroperitoneal. I'll show it to you. Okay, but in this case, just imagine that this is somewhere here, internal, like this uterine here. Then uterine, water under the bridge. Okay, uterine goes over the ureter. It travels towards isthmus. It reaches towards here somewhere. You can see this elevation. That is also uterine. This one. Okay. And this elevation, that is also uterine. So it travels towards uterus. It reaches to isthmus. Okay. Then it travels along the lateral border of the uterus. It gets terminated as a ovarian branch of the uterine. Correct? This is the normal anatomy. Now remember, what do they teach us, or what you guys teach to your students? What you teach? Stay close to the uterus. Stay close to the uterus. Because I was also being taught like same. Okay, be close to the uterus. Be close to the uterus. In fear of what? In fear of this structure. which is far, far away. Now, where are you? Show yourself. You are here. And where is ureter? There. Now, in fear of this structure, if you stay very close to the uterus, what will happen? You will accidentally puncture the uterine at higher levels than where it is supposed to be taken. Where it is supposed to be taken? Isthmus. What is isthmus? For PGs or any assistant lecturers who don't know, what is isthmus? Where upper segment is ending. See, this upper segment is ending somewhere here. So this is isthmus. Okay, so your uterine you should be taking here. But after taking adnexa, if you stay very close to the uterus in fear of that structure which is very far, you will be puncturing the uterine again and again till you reach isthmus. Okay, so the statement, my statement here, once the adnexa is down, maintain 2-3 centimeter distance away from the uterus. Okay, keep on chopping both the leaves of broad ligaments together till you reach isthmus. Okay, so now only cutting. So traction. Okay, same theory as I told, adnexa is down. Okay, what was the traditional teaching? I should cut here, traditional teaching. Okay, my teaching, maintain 2-3 centimeter distance here. So my cut will come there. Okay, now open scissoring action. Keep open like a scissor. Scissor, you don't keep it open like this, like that. Open like that. Scissor, open, keep it open, yeah, like that. Okay, activate and simply close. With activation, simply close. No holding. Activate and continuous, ma'am. Close, yeah. See, any force required? No. Okay, go ahead, keep chopping. Yeah, chop it. Close. Cut, close. Okay, stop. Okay, now you have reciprocated. Now broad ligament has gone down. Now you've reached to the level of isthmus. Okay, this is previous 3 LSEs, but okay, there is no much. There is no much. Okay, now you have reached to the bladder. Now remember, in cases of normal delivery, I wanted to take normal delivery first, any of the previous 3. So in cases of previous 3 LSEs, understand the anatomy. Again, anatomy. Now leave that. Now you have reached till isthmus. Now next step is to step number 3, that is bladder dissection. Okay, bladder dissection. Understand how bladder others. Okay, post cesarean. So let's say this is cesarean section site, like this only, on uterus. Okay, cesarean section site. Uterus is here. You have come from here. Okay, bladder is here. Now post surgery, okay, bladder will come and get other to the section site only. Remember, the plane between bladder and vagina, okay, in 99.99% of the cases, this plane will always be free of adhesions until and unless terribly done. Okay, most of the time adhesions will be here only, at section site only. Okay, now how to deal with this problem? There are 2 ways. One is you have reached here. Okay, so most of the surgeons, they do dissection from here. Okay, till they can do. Okay, then they'll come from left. Okay, then they'll dissect here. Now you have dissected this entire plane. Okay, now you lift off the bladder. Okay, and come to the site of adhesion and chop it. This is technique. This technique is called as lateral window technique. Window you have created below the bladder and laterally you have created. So lateral window technique. I follow my own technique that is developed by me. That is by bang on technique. You can go through YouTube videos. Okay, so and it is much faster. Only thing is you need to have little bit of confidence. Okay, so bladder idea is this. Bladder has come here. Now to deal with this, okay, I maintain adequate traction from above and below both, so that my bladder should not be saggy like this. Okay, my bladder should be taut like this. Okay, like this. Now when you are reaching here, you will identify the uterine. Okay, all the tissues above to the level of uterine, you blindly chop it off. Be confident, blindly chop it off. Okay, once that tissue goes off, you will be able to see this thing. Okay, where bladder has come and what are them. Directly come at the site of adhesion, maintaining the adequate traction from above, below, making the bladder taut like this, and you will come and directly chop off at the site of adhesion. So we will come here, chop this off, this will go down, 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 and you will directly land up in virgin plane. Okay, the same funda, theory, practical now. Okay, maintaining the traction, sir will give you proper traction from below, that is the colpotomizer traction. Now you have reached till the level of isthmus. Hold it. Yeah, okay, so for first step, we will go and come exactly, you can see, close the instrument here, close the instrument, just to demonstrate. This is my uterine. 1 second. This is my vagina. See, that is my uterine. It will be more evident once you give little bit of dissection. Okay, in anatomical way. Okay, so what I told exactly, you can see all this is coming and getting adhered here only. So what I told you, to be confident, come at the site of adhesion. So open completely, yeah, and we will come at the site of adhesion. Scissoring action, ma'am. Open, activate, and close. Hold, open. One second. Without rotating the anatomy. Okay, now go ahead, open. Yeah, chop it off. Chop it off. Yeah, okay. Chop it off. Yeah, you can see bladder. 1 second, don't activate. Open, open. Exactly, you are chopping off the adhesion. Chop it off. Chop. Yeah, don't activate. Open. Chop it off. Open. So this is nothing. This is just some adhesion. Okay, chop it off. Yeah, chop it off. Close. Okay, see, my most of the bladder already I am in the virgin plane. Okay, remember, I believe in more of sharp dissection. How I was taught, put your 2 fingers, push everything. Not like that. Okay, believe in sharp dissection so that you won't get any unnecessary oozers. When you go bluntly, it will start oozing. Okay, so now, sir, colpotomizer. Okay, so now my idea is I want to push the bladder below to the level of colpotomizer. हाथ नीचे करो सर एक बार. 1 second. अरे, they have taken larger. చిన్న కప్ తీసు. ఇదే చిన్నది. ఆహా. Madam, Culpotomy. They have tried to repair it, ma'am, but it is badly repaired. The best would have been mesh, but poly
She was ready for 20,000.
is very bad. From here, see that they have put a stitch here. Okay, from here, this they tried to do it, but it didn't get succeeded. So only main defect is this one only. क्या हुआ? The sheet of dent is nothing. Okay. Just relax the uterus. Okay.
This is also para ovarian. मिला क्या ये? No, hello. मिला? Push. Hold. Hold. Shearer. Shearer, ma'am. Shearer.
Okay, so now we were using the larger colpotomizer so that it was not coming inside completely. Okay, now she has separated the bladder, as you can see. Okay, go inside, don't do anything. Okay, so remaining bladder, simple swiping movement. See, open this. Now I can see when I'm trying to push the bladder, there is no holding. Just close the instrument. You can see one single areolar tissue layer is there. Okay, so I won't go with pushing. Okay, I'll believe in sharp dissection. So this is coming and adhering. Okay, so open it. I'll open the instrument. Okay, so I'll go and chop off the site of adhesion. Chop it off. Scissoring action. Scissoring action. Keep the instrument open. No, wrong. Okay, open. Activate. Don't activate. Close the instrument. Okay, so this is, you can feel this is my colpotomizer. Okay, I just need to take out this areolar band and my bladder will go away. Sir. Open. Okay, chop it off. Scissoring action, ma'am. Scissoring action means imagine like a scissor. No, you are still holding. We will go, keep the instrument open like a scissor. Okay, now activate. Activate, and with activation you will close. Okay, close the instrument now. Whatever you have cut, you will try to push it down. If it is going, if it is not going, again believe in the sharp dissection, no blunt dissection. Okay, see, in entire process of previous 3 also, we are not holding bladder at all. We are simply swiping the areolar tissue, right? All that fistulas and all, remember, when you hold the bladder, your left hand doesn't have that much tactile sensation. So if you crush it, after holding the bladder, lifting it, if you crush it, the smooth muscle will get necrotized. Okay, what happens at that time, even if you check the integrity of bladder, at that time, because with the necrosed tissue is still there, so methylene blue won't leak. Okay, but what will happen once after 2-3 days, that necrosed tissue goes off, you will end up with fistula. Okay, so no holding the bladder. Now bladder has gone below to the level of colpotomizer. You can see that nice white. Okay, bladder has gone below. That is end of bladder dissection. Okay, in onco cases only we go 2-3 centimeter, we separate 2-3 centimeter more of vagina where you want to excise upper 1/3 of vagina. In benign cases, colpotomizer is your target. Okay, only push 2-3 centimeter bladder below to the level of colpotomizer. That is the end of bladder dissection. Okay, now coming to the step number 4, that is taking the uterine. Okay, so taking the uterine, same like open surgery, how we put a clamp at the level of isthmus. Okay, so maintaining anatomy how it is. Okay, again rotate it, sir. Center rod पीछे लेना, push करो अभी. Okay, hold it. Yeah, go ahead. So first shot for uterines, हाथ नीचे थोड़ा, same like open surgery. You will go and grab everything. Your madam must be telling you. For residents, anyone is there here, resident? So madam will be telling, no, kissing the cervix. So this is kissing the cervix, right? So first shot will be given at the level of isthmus. Go ahead, ma'am, fire. And you will relax everything. Sealing, relax. Fire, 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 till bubbles stop. Sir. Okay. Crushed it. Okay. So first shot you gave at the level of isthmus. Then you will move 1 millimeter lateral. Hold it. हाथ नीचे करो सर थोड़ा. हाथ नीचे. बस. बस. Go ahead. Okay. Okay. Then you will move 1 more millimeter lateral. Close the instrument. Have an idea. Careful below. Don't activate. Don't activate. Sir, हाथ नीचे. Hold. So remember, you started there. Okay, how lateral should you go? How lateral should you go? Till the level of colpotomizer. Remember, never you will go below to the level of colpotomizer till you know the anatomy. Okay, for normal benign hysterectomies, colpotomizer is your target. So you will play between isthmus to colpotomizer. Okay, go ahead, fire. So why that happens? Why that happens? Because pushing or trying to do forcefully, instrument jumps off. Okay, just relax. Go ahead. Seal. Enough. Okay, isthmus. All that thing from isthmus to below. Okay, recheck. Okay, above. Okay, so everything is bubble free. That means uterine is ready for cut. Okay, yeah. So you will cut in between so that some sealed portion stays with uterus, some sealed portion stays with body. Go ahead, chop it off. No pulling, no pulling. Okay, imagine like a scissor. Keep it open, activate and close. Again pulling. See, the instrument after cutting it went down. No, I don't want it to go down. Okay, it should stay there only. Why that happens? When you pull the tissue. Once it get cut, you will go and hit something. Okay, yeah. Activate. Arey sir, movement nahi. Activate. No. Keep it like that. Yeah. Activate and close. Simple. You sealed it somewhere in like you. What mistake you did here? You sealed it at one location. You chopped it off laterally. Okay, good. Go ahead. First hold, ma'am. Sealing time, go and hold first. So this is your uterine lumen. Okay, just go hold first. Yeah, seal now. Okay, no bubbles are coming, right? Now, once you see the uterine lumen, okay, once you see the uterine lumen, what is my target? What is my target? My target is to send the uterine lumen below to the level of colpotomizer. Remember, what is ectomy? What is splenectomy? If you take care of splenic artery lateralized, spleen is free, take it out. Cholecystectomy, cystic artery lateralized, gallbladder is free, take it out. Hysterectomy, Hysterectomy, uterine lateralize, uterus is free, take it out. Lateralize means what? When I am going to do the colpotomy to separate the uterus, my uterine should not come in my way. Correct, no? So where you are going to do the colpotomy? At that white. Okay, so when I do my colpotomy, uterine should not come in my way. That means I need to send the uterine below to the level of colpotomizer. To do that, remember the statement. To do that, identify the lumen. You have identified the lumen here. Okay. Now the tissue which is holding the lumen with the uterus. Okay. Keep chopping the tissue which is holding the lumen with the uterus. Continuously you have to assess and continuously you have to cut. So this is the lumen. Which tissue is holding the lumen with the uterus? This tissue. Tissue medial to the lumen. Come and chop it off. No pulling. Okay. Imagine like a scissor. हाथ नीचे करो सर. हाँ. Okay. Chop it off. Holding it before. First stabilize. Your mind is blocked. Okay, just keep it like this. Just reach there. Just keep it like this. Just keep it like this. Just keep it. Now your job is to activate. With activation, you just simply close. That's all. Do it. Keep it. Activate. Scissor, scissor, scissor. Imagine scissor. Reach there. Yeah. No, no, no. Oddu, ma'am. Don't go with blood. If you see the blood directly, seal, seal, seal. No need. Go ahead. Activate. And still very. I want it gradual, slow, just simple closing. That's all. Go ahead. Again. This is the lumen. Which tissue is holding? This tissue. Go and chop it off. Like that. Instrument jumped off or my assistant helped me. Go ahead. Yeah. See, you can see your lumen going down. Okay. Now which tissue is holding the lumen? This tissue. Below one. Chop it off. No pulling. Ravi. First localize. Put the instrument like this. Yeah. Activate. Yeah. Now activate. And close. Why did you stop? Continuous activation till you close. Go ahead. Do you close scissor like this? No, Gada. Only gradual. Let the current go. Okay. Seal change. You will listen to him continuously. Okay. I am leaving it to you and him. Don't worry. He will take care. You listen to him continuously. Okay. He won't stop you. You keep doing. Okay. But if you're doing something wrong, he will come and stop you. Water is down. Okay, once the uterine lumen goes below to the level of colpotomizer, that is end of that side. Lakshmi madam, once the lumen goes below to the level of colpotomizer, okay, that means when I'm going to do my colpotomy, my uterine is not going to come in my way. That is end of that side. Okay, now exact same steps you will repeat it on left hand side.
Yes, sir. Yes, sir. Don't push. Just slowly progress. Just slowly. Don't push. Push. Just go. That is the right. Okay. Right. Okay, always keep electrical instrument in your dominating hand. Okay, so things which are not important start giving to your assistant. Okay, so once you put it, they will be your assistant. Electrical instrument, your starting is always be dominating. Don't try to play both your hands. Okay, slowly, it will come. But easier will be to play your dominating. Okay, so all electrical instrument dominating. So this will come in your right hand. That will be once you have kept it, give it to us. There is nothing there. Just putting it in this. Okay, hold it comfortably. Don't hold the pole. Okay. Left hand. So that's you go to that. That's it. Don't put it down. This is relaxed. See, this is relaxed. Don't ask. Once you start doing the other every time. Do it relaxed. Apply it now. This is your uterine. Okay, so your lower plate here. Chop it. Now take this bit also from here. Yes, perfect. Chop it off. Just stop it. Yeah, put it back. See, that is your colpotomy. No, gentle. Excellent. Right? Now you are okay. Now next step is to uterines. Chalo. Uterine, first shot what I told, isthmus, where upper segment is ending. So you will come here to here. Same, kissing the cervix. That's what you teach it to your students, right? Go ahead. Don't pull it down. Don't pull it down. There is less space. Just hold it. Continuous fire. Yeah. Hold laterally. Go. Yeah. Hold it. Fire. Perfect. Go lateral. Okay. Okay. Still uterine has not been taken, but I'll show you nicely. First you cut little bit here. Array. पूरा Okay, so this is nothing. This is broad ligament. You chop it off first. Wait. Little. Make sure you don't touch. This is very hot. This can cut a tissue. This can open bowel also. Okay. Why? No RBC. Direct sealing. Direct cut. Perfect. See how your instrument stayed there only. Yeah, like that. Go ahead. Continue. Yeah. Now this is uterine. This was broad ligament. Okay, now recheck now from first shot here. Array, the movements and the book. Go ahead. Seal. Okay, now move lateral. How we did that side? Yes, hold it. Perfect. Okay, now move lateral. Little. Having an idea that is okay. Okay, recheck. Make sure you don't touch here and there. Enough. Above. Okay. Then it is ready for cut. Cut there only. Yes. Chop it off. No pulling it down. Instrument should stay there only. Perfect. Now you saw the lumen. Okay, 1 second. Take it out. Which tissue is holding the lumen? This tissue and that tissue. Okay, come and chop it up. Lakshmi madam. Pulling madam. Chop it. Perfect. Chop. Down. Okay. See, when you are going to do the Culpotomy, where you are going to do the Culpotomy? Here. Okay. Where is your uterine? Here. The uterine is not going to come in your way. Okay. So, done with both the sides. Now next step is to doing the Culpotomy.
ఎందుకు వద్దు, నేనే పెట్టినా. ఏమో గవర్నమెంట్ లో చాలా డబ్బులు ఉన్నాయి సిస్టర్. సరే సిస్టర్. Okay, done with colpotomy. Now, sorry, now done with the lateralization of the uterine. Okay, now colpotomy also you can do it with the same instrument. Okay, but I prefer unipolar because it is faster. Okay, so remember in unipolar, okay, have you ever used cautery pencil for cesarean section open hysterectomies? Cautery pencil, right? So imagine that you want to cut with the pencil. How you do? You try to do with the tip of the pencil. Okay, let's say lower uterine segment is oozing, some capillaries are there. Okay, how you try to do? To control that ooze with cautery pencil only. You place the pencil like this, touching the maximum surface with the tissue, right? Have you ever done that? Without even knowing, your brain knows that if I create a less point of contact with unipolar, it will cut only. If I create more point of contact, it will coagulate only. Okay, the same funda here also. Okay, so in unipolar, what type of current you give, cut current, coag current, that doesn't matter. Okay, in unipolar, the point of contact is more important. If point of contact is like a point, it will cut only. What we try to achieve here, cut. So we will try to achieve minimum point of contact. Now this is called as hook, L hook. Okay, so when you activate it, will get activated from here till here, right? So if I want to achieve cut with this instrument, I'll try to do with the tip of the hook, continuously tip, tip, tip. Remember, in entire process there is only touching is required, no pull, no push. Though it is called as hook, no hook, no hooking. This means you are pulling the tissue. Okay, once the this tissue gets cut, you will go and hit something. Okay, so always touch, 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 no pull or push. Okay, so just hold so that I can demonstrate. Come, right side. Right side. Go inside. Okay. Okay. So I'll try to do with the tip of the hook. So we will reach there. Machine convert cheyandi first. Okay. Now you will be convert ayindi. Okay. Now you will be pressing the center cut button. Okay. Just hold it casually. Don't get conscious. Okay. Just hold it casually so that I can show how it should be done. So we will go and reach to the colpotomizer. This is my colpotomizer. Now go ahead, activate. Continuous, huh? Continuous, continue. See, I just keep on touching, 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 keep on doing, keep on touching, sir, stable. Stop, stop, stop. Okay, now again, this we gave the anterior cut, now posterior, center, center, center. Arey, हाथ नीचे, हाथ नीचे, हाथ नीचे. ఏం రాని స్మోక్ ఎవాక్యుయేటర్ పనిచేయట్లే, కొత్తగానే ఇన్వెన్షన్ చేశారు, తీసేసి. హ్యాండ్ డౌన్ సార్, పూరా హ్యాండ్ డౌన్. ఓకే, now you will go come posterior. Okay, one second. Hold some. Hold. Go, 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 go. Reach. Go ahead. Go ahead. Reach to that colpotomizer elevation. Just keep touching and join both the ends. Where is the colpotomizer? Colpotomizer is here. Hold it, relax. Okay. We just need to go there, reach there, just need to touch it. That's all. Keep it continuous, 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 continuous. So continuous, 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 continuous. Okay. Stop. Take it out. Naku white. Come this side now. Right, right, left, left. Same panda. వదిలేయి అక్కడ చూడు. నాకు ఒక 2347 వైక్రీలు ఇవ్వండి. ఓపెన్ చేశారు. Rotate the tip slow, don't push. Go ahead. So that you will be able to see the tip. Sister, here పట్టుకోండి. सर पुश करो सर, कॉल्पोटोमाइजर और हाथ नीचे करो. गो अहेड, गो अहेड. टच टच टच, कीप टचिंग. गो अहेड. Go 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 go. Continuous. Go. No pushing, no pushing, no pushing. Just reach there, activate. Let the tissue get cut by current and not by your force. Just touching is enough. Be there, be there. It will get cut. Go ahead, continuous. Take it out. Okay, now uterus is out. Salpingectomy, salpingo-oophorectomy. Okay, in cases of ectopics and all, you will always come and hold the fimbria. Okay, so మీరు షియర్ తీసుకోండి. షియర్ pumps both ovaries. Acha, you want to remove, everything remove. Remove. Kachani. Okay, so first shot will be given close to the ovary. This is para ovarian cyst. Okay, see, ovary is free, tube is free. It is in meso ovary. Go ahead, ma'am. కొంచెం పుష్ అండి. చేంజ్ అండి. అదే, go ahead. Fire continuously till bubbles stop. Fire, 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 fire. Keep firing. Okay. Okay. One more shot laterally. It has not come. Rotate the tip, ma'am. This side. Take it out. Rotate the tip completely. So you were doing like this. Okay. Is this better or is this better? Correct, no? Go ahead. Hold. slightly above. Hold. No bubbles. Okay, go one more shot laterally. Yes. Don't do it. Cut medially. Relax, no? Right. Yeah. Go ahead. Go ahead. Yes, go ahead. Okay. Keep it there. Okay, come. Let's finish it. First shot close to ovary. This side better, ma'am. This side better. See, first shot close to ovary. Yeah, fire. In cases of ectopics also, lateral to medial. So just hold the tube, keep on chopping the mesosalpinx. Brother, suction irrigation ready button. Happen next that okay. Start chopping. Nice, ma'am. Suction tube. Suction tube. Suction tube. Suction tube. ఇక్కడ ఇవ్వండి ట్యూబ్. निकाल दो सर. Toothbrush, needle holder. निकालो. निकल गया. Tube, ovaries. Hard. शीशे भी सर उंगली डालो सर. సక్షన్ అటాచ్ చేయరా ఫాస్ట్ ఇక్కడ ఆన్ చేయండి సక్షన్. ఏందా ఇంటర్నేషనల్ సెక్షన్ తెచ్చావా నువ్వు? ఆన్ చేయి, అది ప్రెస్ చేయి మంచిగా.
Right job.
గవర్నమెంట్ లో మెయిన్ ప్రాబ్లం అయితే ఇదే. No one is encouraged to do work. Even if I don't work, government will pay the salary. So, okay, ఎందుకు వచ్చాను? Go inside. सर 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 आप क्या कर रहे हो? बंद किया है?
Yes.
ఏ చూడురా సక్షణ,
Second one.
సిస్టర్
ఎవరికి తెలుసా?
ఇంకొక సెక్షన్
Intersection tube. Intersection tube.
అన్ని ఉంటాయి సిస్టర్. తర్వాత సడన్లీ ఒకసారి ఒక్క రోజులో ఇన్స్పెక్షన్ వస్తుంది, ఆ రోజులో అన్ని బయటికి వస్తాయి. అదే ఏం నేను గవర్నమెంట్ లో పనిచేయట్లేదు. అదే ఇదే సెక్షన్. ఇది చూడు, నువ్వు చెప్పావు కదా. ఇంకో okay, so there is no much oozing. Now coming to endo-suturing, I never advise to practice on patient. Okay, always do TLH, suture it from down. Do TLH, suture it from down till you do your initial 10 to 15 cases. Okay, never practice on patient. Now to practice endo-suturing, you don't require endo-trainer. Okay, only just take one tooth grasper like me. Okay, and one needle holder. The exact same steps what I'm telling now. Okay, keep doing the same steps when you are sitting in OPD daily morning. Okay, tell your juniors to bring one chicken piece for you. Okay, daily morning 110 rupees chicken piece. Put a cut. Okay, take one Vicryl. Daily how you used to practice open surgery knots. Same. Okay, what to practice? Now I've kept the needle inside. Okay, what is my aim? My aim is to hold the needle perpendicular to my needle holder. Right, to do that, let's call 3 points. The tip of the needle. 1 second. So this is needle, the tip of the needle, let's call point A. Okay, 2/3, 1/3, let's call point B. This is called as steward's point, or where thread is getting attached to the needle. That is weakest point, don't hold that. 1 centimeter lateral, let's call point C. Okay, with my needle holder, I'll come and hold point C. I'll lift it so that all my danger organs are away. Now I'll go and hold point A. Okay, now it is a coordinated effort between both my hands. Okay, to bring needle perpendicular to my needle holder axis. Once it is perpendicular, go and silently grab it at point B. Okay, this looks easy, but this is only most difficult step of endo-suturing, holding the needle. Okay, now coming to the next step, That is putting a throw. Putting a throw, I'll go hold the vaginal mucosa, bring it outside. Okay, I'll place the needle where I want to come. See, I want to come here. So I place the needle. After that, look at my hand. I'm just holding it with 2 fingers. Okay. After that, it is simple rotation of the needle holder. Simple rotation of the needle holder. Okay. Again, you held it at vagina. Again, simple. Aim needle ichchava. Round body. Thank you, sister. అది చూడు అసిస్టెంట్ చెప్తున్నాడు గవర్నమెంట్ లో ఉన్నాం సార్ okay now next step is to put a knot. To put a knot, there is something called as C reverse C, V reverse V, U reverse U, everything is same. Okay, so grossly I'm making C on the ground. See, C, C. Okay, now go inside C. So that will come 1 and 2. Okay, I'll go and hold the end. Now remember, this is not a hemostatic suture. Okay, it is only for approximation of 2 vaginal ends. Okay, so even if you put one figure of 8 at one angle, one figure of 8 at another angle, that is also fine. Even if you put one single stitch in the center, that is also fine. Even if you don't suture at all, keep the vagina open like this, that is also fine. Nothing is going to happen. But till the time it takes 7 days, okay, for both the vaginal walls to get approximated. Till that time, patient might come to you complaining like some peritoneal ooze, something is coming. Instrument ever wash చేస్తారు సిస్టర్ చూస్తున్నారా ఏంటి
అంటే ఇవి
ఆ?
ఇవి ఇప్పుడైతే నేను వాష్ చేస్తాను.
మీరే కాదు అంటే ఎవరు సిస్టర్ ఎవరైనా నా అసిస్టెంట్ వాష్ చేయరు
నేను చేసేస్తాను.
అదే ఎవరికైనా చెప్పండి ఏం కాదు అది ఓపెన్ సర్జరీ లాగానే వాష్ చేయండి ఇరిగేషన్ ఇవ్వండి
ఓకే ఐడి సెట్ కనెక్షన్ చేయండి. ఐడి సెట్ కనెక్షన్ చేసి ఇవ్వు.
he said and Go ahead, ma'am. Nicely done. Scissors and suction irrigation. Madam.
అది ఎంత హాఫ్ అన్ అవర్ అవుతుంది.
కాలే
అన్ననే ఉంది.
चालू है क्या? స్పిరిట్ ఇవ్వండి మనకు ఏం చూడు జుగాడ్ చూసావా రవి ఇదే మంచిగా గవర్నమెంట్ జుగాడ్ ఒక 7 number గ్లవ్ ఇవ్వండి right? So this is a case of previous two LSES again for hysterectomy. So what before starting with hysterectomy, I'll demonstrate you all the avascular spaces. So it is just for demonstration so that you will have an idea ki even if what is the use of manipulator. When we use a manipulator, what is the course of uterine, how it comes and how it goes, from where it comes and what is the relation of a uterine with ureter, our most important structure. Okay. सर नीचे डाल के इनको दे दो ना एक जन को दे दो
కాలేదా అయిందన్న వైట్ చేంజ్
కొంచెం ఈ సైడ్ తీసుకోదు okay. So remember always whenever you want to go to retroperitoneal, always your IP pass. So we will go and just open up the peritoneum. Okay, I'll go and open up the peritoneum. Sorry, so you need to enter between this was round ligament, this was like this. Okay, so ideally your entry should be between in a triangle of round ligament, externa ilia. This is your externa ilia. Okay, now within a minute your interna iliac will be visible. Patient is on the spinal GM. Okay, so this is rectum, this is sigmoid and rectum. One second. Mila, push and sit down. So understand all the avascular spaces. Don't just like believe in theory. If any residents are here, yeah. So in cases of obstetric internal iliac ligation, okay, there is nothing. If you just open up a peritoneum, okay, every structure is just in front of you. Okay, hand down, కూర్చోండి. Okay, so hand side. Yeah, okay, so I'll just open up little bit more for you so that anatomy will be easy. So this is your ureter. This is your ureter, right? Now understand what are the avascular spaces. Okay, normally in obstetrics and gynec, one space we normally open always. Okay, that is our vesico-vaginal space. Okay, so there are two paramedian spaces. Okay, that is called as, this is rectum, hand down, ma, hand down, push and hand down. Okay, completely down. Yeah. So if this is rectum, okay, this is, second, go inside is little bit of sigmoid adhesion. Just restore the anatomy before starting the procedure. What, ma'am? Bringing no normal case. But why this thing is other? So it is interbowel adhesions. Okay, so your sigmoid. Okay, so this is intersigmoid. Okay, so sigmoid is coming like this. This is not a normal this thing, but I'm just restoring the anatomy. Okay, so sigmoid went below. Now this is rectum. Okay, this is rectum. Now paramedian spaces, that is pararectal spaces. Okay, so this will be called as pararectal. All the space parallel to rectum, that is pararectal space. So this space is pararectal space. Now this pararectal space is divided into medial and lateral pararectal space by ureter. Ma, hand aside, muttam, inka. Okay, so you can see your ureter somewhere here. This is your ureter. Okay, see this one second. I'll make it more evident. Okay, see this is your ureter. Okay, now if I enter, okay, medial to this, medial to ureter, this is my medial pararectal space, or in between ureter and this thing. If I dissect this plane, ma, hand aside koncham, hand down करो सर और थोड़ा सेंटर पे आओ, hand अरे 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 हैंड मेरे साइड करो, मेरे साइड and hand down. Okay, this is like some adhesion we can see, but I think we will just chop it off. Okay, so keeping this thing medially, this is my para and ureter stays laterally. Okay, this is my ureter. Okay, so I am medial to ureter. So if I go, I'm doing it with one more port. We require one more port. So if I go and dissect this plane, this keeping ureter lateral. So this is my medial pararectal space. Okay. The only ones that is also called as Okabayashi space. There's only one structure, okay, comes in this thing is hypogastric now. Okay, meanwhile it will be visible. Now we'll focus on our more important space, that is our Glasgow space, that is lateral pararectal space. Now this is ureter, I am holding the ureter. I'll keep dissecting lateral to the ureter. First structure will avoid me to go below, will be our structure, that is my uterine. So I'll keep on dissecting. Okay, so mostly I feel like this should be the uterine, but it will be more clear now. This. So this is all your parametrium. Okay, this is all this. So this is your uterine, this one, this structure. Okay, one second, I'll show it to you more nicely. Now see how uterine is going and how ureter, this is my ureter. This is ureter is entering into Wardheim's canal or ureteric tunnel. This one, see, this is my ureter. How it is entering, how uterine is crossing. This is my uterine. Okay, so remember now. See, uterine is coming where? Now I'll dissect little bit here. Hand up, ma. Push and hand up. Go. Now because push. Ah, and our side, sir. I, ah, hmm. ఏంది నీకు previous normal కావాలా? ఇదే previous section. Okay, so the same how she dissected in the last case, same. So this is my vagina. Okay, this is my, one second, it will be more evident. See, this is my vagina, this entirely is bladder. So this is that lateral window what I was talking about, right? Now forget about that lateral window, like bang on, I'll go exactly at the site of adhesion, chop it off. Exactly at site of adhesion, chop it off. Here I saw my plane, so I'll go chop it off. Again, go chop it off. Keep chopping it off. Okay, these are some areolar tissue. Let it go. Okay, see, beautifully bladder has already gone below. Okay, now I wanted you to see the anatomy of uterine. One second. It will be 2 minutes. It will be more clear. Once I send my bladder down. Pushing up, push up, and this side. Push नहीं कर
Light off చేయరా?
come back. So this was my uterine. Okay, so see, this is my uterine. 1 second. Okay, so this is my internal iliac suction. Fast గానే prepare చేయండి. Okay, so see, internal iliac gives uterine before, then it gives you the last branch of your obliterated umbilical. Okay, that is the content of median umbilical ligament. See, this is median umbilical ligament. Okay, so this is your external iliac artery. If you plan to do lymph node dissection, maybe you will get, see, this all this fibrofatty tissue. I'm just for demonstration, I'm just chopping it off. See this, right? This all this fibrofatty tissue, small, this thing is there. This is lymph node. So remaining parallel to the vessels. See, entire external iliac lymph node is done. I'm just trying to demonstrate you. I'm not going to do lymph node dissection here. Okay, so this is your external iliac artery, external iliac vein. Okay, this is your internal iliac. This one. This one is your internal iliac. Internal iliac gives uterine. This is your uterine below. See, uterine will be nicely. See, now this is uterine. Push, madam. Don't relax. Okay, now it is visible. See the anatomy. Now, what I'm, sir, hand that side. Where is ureter? Ureter is here. This is your ureter. Okay, where it is entering here. Okay, see uterine, it is originating here, then it is going here, then it is going here. More it will be visible. 1 second. This is all fibrofatty tissue. Yeah. Okay. So this was your ureter. Okay. This is entering here. Now push hand down. I want to demonstrate. Now, when you are here, okay. So when now I am coming from here. 1 second. I'll chop off this adnexa, so it will make the anatomy more clear. And this side, ma'am.
Tubes ovaries, ma'am. We have to take it out. Tubes ovaries, we are taking it out. Tough one. Hmm. Okay, so it is entering somewhere here. Okay, so now push, ma, push. When I told you in the first case, ke don't go below to the level of suction irrigation. Fast, fast.
Irrigation, sir.
Mhm. Vein, flat bipolar. Flat bipolar, ma. Okay. Suction check. Posterior side. convention. Come on, surgeries. Hmm. So, what my idea for this dissection is, like when I tell you, okay, when you are taking the uterines, okay, so you are taking uterines from here till here, okay, from isthmus to colpotomizer, okay, this is only ureter. This, see this one, this structure, because of this blood, everything, vein, okay, so this is ureter. Now this is your colpotomizer. What I told you, never go below to the level of colpotomizer, this level. If you go below to the level of this level, you means like if I go and hold like this, there is a chance I might give thermal injury to this structure. Okay, so always stay above the colpotomizer. Okay, just take care of this vein. So my boss used to always tell, veins are like females. It can get punctured very easily. Okay, and it is difficult to control them. And at the same time, it will spoil the vision, it will spoil the field. That's what it has done. Like arteries are like males. You cannot puncture them easily. Once it punctures, it will bleed like anything, but it is easy to control. It is like same like because of the thick walled nature of arteries and thin walled nature of veins. Irrigation. Okay. అదే బ్యాక్ సైడ్ లో పంక్చర్ అయింది. Okay, so we will go and hold everything together. Okay, so this is where I'm giving my first shot. Now my second shot at the level of colpotomizer. First shot here, here. So it is like I'm just showing you it can be done with only bipolar and scissors. Now you have done with bipolar, there is no need for any extra instrument. I'll go and simply chop it off. Push. Okay, funda remains the same. Once I see my uterine lumen, this is my lumen. See this one. This is my lumen. Okay. Shear this corner. Array. So this was my lumen. ये भी ट्राई कर लेंगे. कहाँ गया? Okay, so this was my lumen. I'll doubly secure it and I'll chop it. Cervix was healthy, no ma'am? Okay, so I'll keep on chopping. Okay, so that's what I wanted to show. your both the anatomy. Now uterine anatomy, ureter anatomy. This is my ureter. This is my, see, this is nothing, just fat. Right, this is my uterine. If I lift it off, so what is radical? Radical is nothing. If I take uterine, this is my origin, uterine artery at origin. I just simply chop it off. Okay, and I just see, I'm just flicking off uterine. See my uterine. Okay, it is getting flipped off, and I have just put uterine from this side to that side. No, this is highly vascular. That's why I was asking कि cervix is bulky, yeah? Hmm. It's very vascular. Normally, this won't be like this much. Okay, but I have taken like a radical only. So I have removed. See, this is my uterine. Okay. At this moment, it is very close to the ureter. This is my ureter. See how beautiful it has come. Entire uterine. So radical is nothing but if I keep ureter like this, okay, and I start chopping off here, so that all this parametrium also will come. Okay, so that becomes radical. Okay, you can see this. This is superior vesicle. Your another branch of internal iliac. This one. It is very vascular. At the same time, this is your superior vesicle. This one, this artery. See how it is going into bladder. We have to do internal iliac at the internal iliac. See where is the internal iliac? It's here. All this vein actually spoils entire vision. Suction piece. You can see now external iliac, internal iliac. At least see. This is your what's it? Okay, this is your common iliac. Now picture is little bit more clear. ಸ್ವಲ್ಪ పంచట్లేదు ఇది సక్షన్ ట్యూబ్ చూడండి సేమ్ గవర్నమెంట్ లాగా ఫీలింగ్ ఇస్తున్నారు సో who asks you ask, okay, so this is your external iliac, this is your internal iliac. Okay, this where it gave uterine here. Okay, if you go back side there is obturator also.
sir.
Sorry.
AC.
అలాగే ఉంటుంది. ఒకసారి ఆన్ చేస్తే అలాగే అయిపోతుంది. నాకు షియరర్ ఇవ్వండి మా. షియరర్ ఇవ్వండి. Okay, so the answer to your question is this is where it is giving in this one. Where? Here, this one. This is your uterine origin. What I cut it and I reflected here. This one. Okay, like this it was. Okay, so when you want to do what I am holding, this is my internal ileum. See this. So you will pass a mixture below this. Matlab in lap it is not possible to tie internal iliac. Okay, but when you have a right angle like this, so you will put it below internal iliac at this level. At this level. Okay, you pass it. That will be your internal iliac. See, nicely it is visible. 1 second. Vein doing. ఎక్కడ నుంచి వస్తుంది? అదే ఓకే ఈ సైడ్ అక్కడ నుంచి ఓకే See, understood that at me now? Okay. Another that thing so you will be knowing only. This thing, this is your pectineal ligament, you know. Right, pectineal ligament you will be knowing. Just yes, obviously. All vein will be accompanied by its arteries, no? So this is your artery. This is your external iliac artery. Okay, so internal iliac, external iliac vein. 1 second. This is your external iliac vein. Okay. Now this is my fibrofatty tissue. This contains external iliac lymph nodes. I'm not supposed to do, but there are no lymph nodes here, so I'm just simply chopping it off. Okay. Now this is nothing. That is not our job now. Pathologist will identify. Yeah, you just like remove this fat surrounding this. Okay, sometimes when lymph node, sometimes when lymph node is enlarged, it will be visible. In this case, so nothing is there. Okay, now we have reached to our another important structure, that is your pectineal ligament. Okay, so see this. 1 second. Okay, so this is, you can see this vein, this getting filled, getting emptied. This one. Okay, so this is connection between, here is your obturator vein. 1 second. It will be more clear. I'll dissect a little bit more. See, I have reached my pubic muscle, levator ani. This is my levator ani. Okay, so this everything except ureter. If I just chop it off and flip it this side, that will be radical. Okay, there are no vessel. Now coming to this thing, understand what is this. This is called as corona mortis, where you can see this, where it is coming from here. Okay, one second. Here, where obturator vessel is entering, this. Okay, so this is connection between this obturator vein and it is coming with extrailiac vein. So it is anastomosis between obturator vein and extrailiac vein. Okay, so but this is commonly known as corona mortis. This one. Okay, because like when you come for this was named by orthopedicians. So when they are dealing with what do you say some fractures of hip. Okay, so they'll be coming from front to back. So they will never see this vein. Okay, and if you puncture this vein, again, vein is vein. So it will spoil the field. It will ooze like anything. That's why they named it corona mortis. Anything more? Any questions? I think uterine anatomy I have taken care. Okay. This is also good. This is nicely. See how uterine is entering totally. Now I'm not able to pull it off. It has gone inside uterine tissue. This is spoiling. Check. Okay, side.